And lastly, do we have any Purdue grads? Yes. So you better like this slide then. All right. This happens to be the kicker for Purdue. And also is a close friend of mine as well. All right. So let's go ahead and get started. And as Bill may have mentioned to you a couple days ago, the goal of this EBM course is really just to give you a taste, a feel, a flavor for this. All right? Kind of give you the big picture, the overview, kind of give you a foundation on which to start to build things. And also, you're going to start learning a new language, new terms, new nomenclature, and things like that. And so hopefully over these next couple weeks, you'll start to feel a little bit more comfortable with the concepts. You'll start to feel a little bit more comfortable with the wording and how we do things as well. I think on Tuesday, and also for the people who went through the Tuesday discussion group, you talked about randomization, you talked about intention to treat analysis, you talked about risk reduction and number needed to treat and things like that. And for the groups today, that's what we're going to be going through this afternoon. Unfortunately, I kind of get the toughest talk in regards to going through some of the things in the diagnosis module. And hopefully we can get you through that, and it won't be too painful in doing that today. But diagnostic testing compared to the therapy module is a little bit tougher as far as some concepts and some of the math and things like that. Please remember that you don't learn this stuff overnight. In fact, I have to make a confession. I've given this lecture now for about 4 years. I still have to go back and review this material every year to be sure I still have it in my mind and still can use it and still can verbalize it a little bit. So don't get frustrated if it doesn't intuitively come to you the first time you hear it. It takes time and it takes work. That's why we have the practice sheets. That's why we have the small group discussions in order to drill down on those things. As Tony mentioned, the lecture slides will be on the Angel website. And I guess I'm being recorded as well for the Angel website, so I'll try to keep my 4-letter words to a minimum today. What you need today is essentially a piece of paper and a pencil. And for those of you that may have your red cards, you may want to pull those out. Again, everything else, the lecture, things like that, is going to be on the website. So I really just encourage you to kind of sit back and think about this as we kind of go through the next 50 minutes or so. So what are our objectives for this hour? One, we're going to spend a little time and ask a very simple question on why we do tests. We do lots of tests in medicine, but we need to know why we do that. We'll talk about decision-making thresholds. We'll talk about study design for diagnostic testing. Then we'll spend a fair amount of time looking at 2x2 tables and then also describing the validity of a test. And that's really where the new nomenclature and the new language comes in. For some of you who may be stat jocks, some of this may not be that tough. But for others, it could be a little bit on the painful side. So, why do we do tests? If I'm not mistaken, all of you right now are doing a CDH case-based study, is that right? With Mr. Kincaid, who has some chest pain when he's running. Have you guys gotten that yet? Okay. All right, so already you've been introduced to a clinical scenario, and with Mr. Kincaid, you've been given some tests and results of tests, and already you're starting to learn how to move along kind of the diagnostic line in making things more likely as far as the diagnosis and starting to exclude things. So the reason we do tests really a lot of times is to move us in one direction closer to a diagnosis, or the opposite, moves us away from a diagnosis so that we can rule that out and then move on to something else. We do tests to change the medical management of patients. If Mr. Kincaid's EKG was not normal, but it showed acute myocardial infarction, that immediately, for Mr. Kincaid, would do what? It would change what we're going to do for him. An EKG is a test that would change management within the first few minutes or so. It also helps us define and determine severity of disease. It helps us prognosticate at times as to what's going to happen or what may happen to that patient in the future. And lastly, it also helps us assess the response to therapy. Now that we have done this for the patient, let's go back, retest the patient, and see if we've improved things. But we also do tests for other reasons as well. A lot of these are less scientific. You just want to be sure in your own mind, right? You want to be complete. Many times patients come to us and they want a specific test done. Patients today are much more informed consumers of health care than they were 10 or 15 years ago. So patients will come in and say, "Doc, I think I need to have this test done. What do you think?" Also, unfortunately, at times we practice in a litigious environment, and sometimes tests are ordered just to practice what we call defensive medicine. And lastly, at your stage of training, and during especially your third year of medical school, when you're on different teams and different rotations, the reason you're going to order a test is somebody else told you to do it, and you probably should do it. But there's no free lunch. Testing can give us a lot of information. It can let us help patients, but there's also downside to testing as well. Has anybody in this room had an MRI? Whoa. Quite a few people have had an MRI. Did it take time? Yes, it probably took a half a day out of your schedule in order to get that test done. It may not have cost you personally, but it cost your insurance company a fair amount of money, didn't it? At times, tests give us unexpected results. We were expecting A, but lo and behold, B popped up on the radar screen. Now what do? There can be complications to testing as well. If you're given intravenous contrast for a certain type of radiologic study, you can have an allergic reaction to that. A woman goes in for a breast biopsy, and 3 days later she develops an infection from the procedure. So testing can cause complications as well. There may be disparity in interpretation. If you give 5 cardiologists an EKG, you may get 5 different answers. Tests that require interpretation, right, are a lot tougher because it's not nearly as black and white. Many times it's gray. There's emotional anguish that goes along with testing, the worry of what the result is going to be. And a lot of times we use tests as opposed to actually sitting down and talking with patients. Sometimes it's easier just to order that test and not sit down and try to explain to a patient why they may not need it. And really one of the take-home points of this lecture is tests can be wrong. With tests, you can get false positives, and also you can get false negatives. So testing is good, but testing has downsides as well. So one of the take-home points today is testing, diagnostic testing, the results of that testing. Unfortunately, at times you're going to get false positives, and you're also going to get false negatives. And diagnostic tests many times are not definitive. We talk in terms of certainty or probability or the possibility of having this diagnosis or the likelihood of this patient having this diagnosis. Many times tests don't give you the definitive answer that is 100% correct and is never wrong. This is an analogy, I think, which may help conceptualize this a little bit. What do you want a jury to do? The jury in this situation is the diagnostic test. What do you want a jury to do when it's charged in a lawsuit to determine guilt or innocence. What you want that jury to do is you want it to convict the guilty, i.e. the true positives. You also want it to acquit the innocent, the true negatives. What you don't want a jury to do is you don't want them to convict the innocent and send them to jail, which would be a false positive. And you also don't want to let those bad guys go free, which would be false negatives. And so you want the same thing with diagnostic testing as well. You want the true positives, you want the true negatives, but you want to minimize the false positives and the false negatives. Try to think of making a medical decision kind of along this line. And let's go back to Mr. Kincaid and his running and having the chest pain. What do you think the diagnostic probability is that he has pneumonia as the cause of his chest pain? Low, moderate, or high? Low, very low by the circumstances and the scenario you were given in that case. So already what you've started to do is you've started to kind of plot where Mr. Kincaid is on this diagnostic line as far as the probability, the possibility, the likelihood of him having pneumonia as the cause for his chest pain. And so what you've done is you said, well, I don't think it's very likely that he has pneumonia. So what you're telling me and what you're saying is really right now, you're working down here on this part of the line as far as your diagnostic probability for him having pneumonia as the cause of his chest pain. Are you certain he doesn't have pneumonia? Are you absolutely sure he doesn't have pneumonia? He had a little bit of cough a few weeks ago, didn't he? So it's still in the possibility or the realm of possibility that he could have pneumonia. So really right now, you're where? You're kind of in that gray zone of uncertainty, although you're kind of down toward this end. So what do? You order a test. And what that test might be for him? A chest x-ray. All right? And that chest x-ray will give you a result. It'll give you a positive result, or it'll give you a negative result. All right? And if that test is negative, which we think it probably will be, we probably have moved all the way down here where we don't need to consider pneumonia as a possibility for the cause of his chest pain. Likewise, with Mr. Kincaid, what's the possibility that his chest pain could be cardiac in nature? Low, moderate, or high? Moderate or high at least. Again, what was he, 50 years old or close to that? Exertional chest pain, had some diaphoresis. That would make me worried as well. So what did they do when he came to the emergency department? They got an EKG. They did a test. All right? Because they wanted to know right away if he was having an acute myocardial infarction. But where did we start with Mr. Kincaid as far as his possibility of having a cardiac cause for his chest pain? We didn't start down here like we did with pneumonia, did we? We started more up here. Now, I know Mr. Kincaid's EKG was normal. So we've taken that pretest probability or that likelihood, and we've probably moved down this way then as far as the possibility of him having a myocardial infarction. But let's just suppose, or let's pretend, that his EKG shows an acute anterior myocardial infarction. All right, so we started here, we did a test, and boom, now we're probably over there, aren't we? We're almost certain, given the clinical scenario and given the EKG now, that he's having an acute myocardial infarction. So we've gotten out of that gray zone, and we've gotten to the point now where we're certain enough with the diagnosis we're going to do what? we're going to start treating him. And that's what testing does, and that's what pretest probability does, is you start with a pretest probability, you start with a likelihood. It doesn't have to be a percentage. It can be low, moderate, or high. You do a test, and consciously or unconsciously, it helps you move down or up this line. And so that's what decision-making thresholds is all about. Now, I want to step back for a second and just be sure we got a couple key terms that everyone appreciates and understands, because we'll be using this as we go along. One is probability. Probability is how often something happens divided by the number of tries. And this is similar but different than odds. Odds is the probability that something will happen divided by the probability that it won't happen. I get confused by these definitions. I like to keep saying things simple. So just think of this diagram, and if I blindfold someone, put this up on the wall, and they throw a dart at it, what's the probability that they'll hit a yellow box? It's 1 in 4. What are the odds that you'll hit the yellow box? 1 in 3. So that's the difference between probability and odds. And if you keep this picture in mind, I think it'll be helpful to remember the difference between the two. Don't worry about it, but just be aware that you can calculate probability from odds, and you can calculate odds from probability. So mathematically, you can go back and forth between the two. And we'll actually do that a little bit later. Don't worry about the math, though. Just know that you can go from one to the other and convert back and forth. The other thing to remember about probability and odds is once you get to less than 10%, they're essentially equal. All right? Essentially equal. And let's take Reggie Miller, who is one of the best free throw shooters in the history of the NBA. And he makes about 90% of his free throws. Right? So if he's at the line getting ready to shoot his next free throw, the probability of him missing is 1 in 10. The odds of him missing are 1 in 9, and you can see now how close they are to each other. So once you get down to less than 10%, probability and odds are pretty much the same. All right, now we're going to start looking at testing. And there's two things about testing and the tests that you order that you need to know about. One is its validity. How valid is this test? In other words, does it measure what it's supposed to? Does it measure the truth? That's what we want a test to do. We also want a test to be reliable, so that for the same specimen of blood, if you're checking the glucose or the sugar in that blood, you run that blood 10 times on the same analyzer, you get the same result 10 times. So you want validity and you want reliability. And think of the bathroom scale. Now, when we get on the bathroom scale, even though we don't want to admit it, we want to know the truth. All right? We want to know what we weigh. All right? So the bathroom scale, all right, we want it to be truthful and give us what we really weigh. Also, we want it to be reliable, that if you get off the scale and get back on, you get off the scale and you get back on, that you get the same result each time. Now, some of us with the bathroom scale may cheat a little bit. And actually, you can move that dial and move the indicator such. So maybe you actually weigh about 5 pounds less than what it really says, or vice versa. Now, you get back on and off that scale, you get the same answer each time, but is the result valid now? No. So tests can be reliable. You get the same result every time, but unfortunately at times they may not be valid. All right, so what I'm going to try to do is to give you a real-life scenario here and see if we can start to draw some of this stuff together. How many of you do your own shopping? How many of you buy watermelons? All right. And when you buy a watermelon, do you check it in any way to see if it might be ripe? Because what you want to do when you go to the store, do you want to buy a melon that's not ripe? No, you don't. And so sometimes if you just go to the grocery store and you go over to the produce section, you'll see people go up to the melons, they'll thump them, and sometimes they'll pick them up and they'll shake them. And you know what they're doing? They're doing a test. And they're doing a test to help them determine whether or not that melon is ripe. So, what we're going to try and do here in the next little bit is to really see how good that shake test is in diagnosing a ripe melon. Now, we all know, though, that if we're buying grapes, what do? We just actually sneak one and eat it. All right. So now we have this question. All right. How good is this test of shaking a melon to really determine whether or not the melon is ripe or not? So we need to design a study to see how good this test might be. And so what attributes and what qualities of this study do you want? First of all, we have to compare the shake test to some type of reference standard or a gold standard. So what do you think that reference or gold standard for our test should be? What would be the best way to find out if that melon was ripe?
Actually cutting it open and taking a bite.
That's exactly right. Cutting it and taking a bite and deciding whether or not it's ripe or not. And so that would be our reference or gold standard. It's a good idea that the person doing the shaking and the person over here doing the tasting should be two different people and should also not in any way know the results of what each other are doing. Why is that? Because if I shake it and he knows that I shook it and I thought that it was ripe, it might influence his interpretation. So that's why you want blind comparison between the test and the reference standard. I think we'd all agree that we'd want an appropriate spectrum of melons. I think we'd probably want to go to Sam's. We may need to go to Marsh. We may need to go to Kroger's and get a variety of melons. We want an appropriate number of melons. Do you think 10 would be enough to really see how good our shake test is? Probably not. And actually, you can calculate statistically how many melons you would need to test in order to get a valid result. And again, we want independence between this test and the gold standard as well. So these are some of the characteristics or attributes of a diagnostic study, a diagnostic test study that you want to have. And we'll drill down on these a lot more during the small group sessions. Now, what you can do then is once you've done your test, you can plug it into one of four results. And by convention, the test goes on the side, and the reference standard, the gold standard, the truth, goes across the top. And not surprisingly, like we said before, tests sometimes are wrong. We can have false negatives, and we can have false positives. So the 2x2 table for our shake test would be as such. that if person over here shook it, said, yes, I think it's ripe, person over here then takes that melon, tastes it, and says, yes, it's ripe, that would be what? That would be a true positive. Person over here shakes it, says, no, not ripe. Person over here tastes it, says, not ripe. What are those? True negatives. Person over here says, no, not ripe. Person over here says, yes, it is ripe. What would that be? And then also the vice versa as well, and you can have false positives. All right. So you can now see that you can take the results of your study and put them into a 2-by-2 table. And this is exactly what we have done. Now, these numbers are just made up. We did not actually go out and do this. All right? And what we found were that we had 73 true positives. We had 81 true negatives. And then we also had some false positives and some false negatives. So now we have these numbers and we have these results, but what do we do with them? We think we've done such a good job with this test that we want to publish it in the European Journal of Watermelons, all right, to show everyone how good this shake test is. But how are you going to tell someone else how good the test is? And that's then where we start talking about the nomenclature and using different ways of describing the truthfulness or the validity of a test. And those things include sensitivity, specificity, positive and negative predictive values, and then lastly, likelihood ratios. All right, this is where it starts to get a little bit harder. All right, if it doesn't come around the first time, don't worry, you're going to get hit with this again. In the small group sessions, you're going to get hit with it several more times. Definition of sensitivity. Given a patient with a disease, what's the chance that the test is positive? In essence, the positive in disease rate. And what it is, it's the true positives divided by all those that have the disease. Or going to our jury analogy, it's how good our jury does in convicting the guilty. So it's the true positives divided by the true positives plus the false negatives. For our example is, we know the melon is ripe. How often was the shake test positive for the ripeness as well? And that's sensitivity. Given that the melon is ripe, positive ripe, right? How often was the shake test positive as well? So 73 over 92, we now have a number. The sensitivity of our shake test to determine ripeness for a melon is 79%. The converse as well, specificity. Given that a healthy person does not have the disease, all right, what's the chance the test will be negative? Or, in other words, the negative in health rate. And it is the true negatives divided by all those without the disease. Or again, our jury analogy, how well our jury does in acquitting the innocent. And for our analogy with our melon study, we know that the melon was not ripe. How often was the shake test negative for ripeness as well? We know that the melon is not ripe. How often was the test negative as well? So it would be 81 over the total of these two, 108, and we now have a specificity of 75%. So we have a sensitivity of 79%, a specificity of 75%. Stay with me. Positive and negative predictive values are other ways to describe the truthfulness or validity of tests. Here, we're not starting with whether or not the melon is ripe or not. We're not starting with whether or not the patient has the disease or not. We're starting with whether or not the patient has a positive or negative test. And so what we're doing is we're looking at the true positives divided by everyone who has a positive test. And really our example here is the shake test is positive. How often is the melon ripe as well? And again, the difference is for sensitivity and specificity, we started with the gold standard. We started with whether or not it was ripe or not, and then saw how the test performed. Now, with positive and negative predictive value, instead of going up and down on our 2x2 table, we're going side to side. Given that our test is positive, right, how often was the melon ripe? So the positive predictive value is 73 over 100, or 73%. And that's our positive predictive value. And you can do the same thing then for negative predictive values. Given a patient with a negative test, what's the chance the patient is well, i.e. does not have the disease? And our example here would be the shake test is negative. How often is the melon not ripe as well? Given that the test is negative, how often was the melon not ripe? 81 over 100, and we now have a negative predictive value of 81%. Don't worry if it didn't click the first time. All right? Let's keep going. Trust me. Hard to do. All right, let's go back to our line now. All right? This is our line where we're trying to move up and down to make diagnoses and to exclude diagnoses. And to move up and down this line, what do? We do testing of some type. And now we have a little bit better handle on how well the tests perform. And so I think everyone would intuit and everyone would agree that if you have a very good test, if you have a very valid test, the results may be, if it's positive and you're here, it may take you all the way out to the point where you're confident with your diagnosis and you start treating the patient. But if you know that tests and the characteristics of that test and know that its sensitivity and specificity are not that good, and therefore the validity of that test is not that good, is it going to move you as far down the line? Probably not. It may help nudge you some, all right, but it may not take you all the way to the point where you say, I'm confident in my diagnosis, I'm going to start treating this patient. But it's hard to visualize that and appreciate that thinking about sensitivity and specificity, negative and positive predictive values. And so we go one step further, and we talk now about likelihood ratios. All right. You have a positive likelihood ratio, and you have a negative likelihood ratio. A positive likelihood ratio is defined as, what's the chance this positive test came from someone with the disease compared to someone without the disease? A negative likelihood ratio is defined as, what's the chance this negative test came from someone with the disease compared to someone without the disease? And you get a number when you calculate this. And you'll see in a minute how it helps us. likelihood ratios greater than 1 increase the chance of a disease. Likelihood ratios less than 1 decrease the chance of disease. And a likelihood ratio of 1 is a useless test. And I'll show you in a minute. All right, positive likelihood ratio. What's the likelihood that this positive test came from someone with the disease compared to someone without the disease? What are we really doing with that definition? What we're really doing is we're taking the true positive rate and we're comparing it to the false positive rate. We're taking the true positive rate and comparing it to the false positive rate. And with sensitivity and specificity, all right, you can determine what the true positive rate is, the false positive rate is, and mathematically then, you can actually come up with this number, right? And in order to calculate a positive likelihood ratio, you take the sensitivity and divide it by 1 minus the specificity. Don't worry about the math right now, all right? And once you have this number now, you can take your pretest probability, or where you are on that diagnostic probability line, and apply it. But you have to convert from probability to odds. That's why I mentioned probability and odds earlier. So if we take our melon and we take the shake test, plug in the numbers from our sensitivity and specificity, we come up with a positive likelihood ratio of 3.2. What does this mean in English? What this means in English is a positive shake test is 3.2 times more likely to be found in a ripe melon as opposed to an unripe melon. Or, probably easier to intuit, a positive shake test is 3.2 times more likely to be a true positive as opposed to a false positive. All right. Now, I mentioned you need to convert from pretest probability to odds. Do not worry about that. But now, let's take this likelihood ratio and let's apply it to something. From your experience, when you go to the store and you buy melons, about 70% of the time, all right, just by picking up a melon that you see, you're right as far as it being ripe. So in essence, the pretest probability of finding a ripe melon by just pulling one out of the bin is 70%. But now we have a test that we can use, all right, that may actually change our probability and actually calculate a post-test probability of whether or not that melon is ripe or not. And so if you take if we convert probability to odds, multiply it by the likelihood ratio, we get 7.5. We convert back to probability, and our post-test probability now is 88%. Don't worry. Essentially what we've done is this. We had a pretest probability of 70%. Our shake test was positive. Now we feel pretty confident that probably close to 90% of the time we've gotten a ripe melon. This is hard to visualize this way, but a smart guy makes it a lot easier for all of us. Dr. or Mr. Fagan, I'm not sure. Pretest probability right here. All right? Likelihood ratio right here. Post-test probability over here. All right. Remember we said that our pretest probability of just going in and getting a ripe melon was 70%. We also know that our shake test has a positive likelihood ratio of 3.2. So all you have to do is to draw a line. And all the math and everything is taken care for you. And also visually, I think it helps you a lot now because you can see that when you have a positive likelihood ratio, what does it do? It's now taken your pretest probability from 70% and raised it to almost 90%, which would make you feel pretty good that you what? That you got a ripe melon. Now, if our pretest probability is 50%, which means is that when you go in, you have a 50-50 chance of picking up that melon and getting a ripe one or an unripe one. But now we do the shake test. The post-test probability is about 75 to 80%. Right? So we've moved it up, but not to the point where maybe we feel quite as confident as we did with our prior example. You can also see that if your likelihood ratio is higher, remember, the more it is greater than 1, the more it's going to influence that test to be positive. All right? Let's say you had a likelihood ratio, of 7. You can see now that your post-test probability is about 90%. All right. Likelihood ratio negative. Yes? That's a great question. It's going to be based upon your experience. It's going to be based upon prevalence. And we're going to give you an example in just a minute. And you're right. Sometimes trying to determine what your pretest probability is kind of tough to do. But we actually already did a little example of that, didn't we? With Mr. Kincaid. All right? What did you think our pretest probability for pneumonia was as far as the cause of his chest pain? We thought it was low. So we started down on this end of the line. But our pretest probability for this maybe being a cardiac cause for his chest pain was much higher. So what we did is we started up here with Mr. Kincaid as far as potentially it being a cardiac cause for his chest pain, but we would have started down in here for his pneumonia. Excellent question. Now, likelihood ratio negative. What's the likelihood this negative test came from someone with the disease compared to someone without the disease? And essentially what we're doing, we're comparing the false negative rate to the true negative rate. And again, using sensitivity and specificity, we come up with a number. And we can calculate that out. And the negative likelihood ratio for our shake test is 0.28. And what does this mean? A negative shake test is 0.28 times more likely to be found in a ripe melon than in an unripe melon. Or, probably to phrase it easier for everyone, a negative shake test is 0.28 times more likely to be a false negative as opposed to a true negative. Or if you wanted to think that and flip it around, you're going to get a true negative about 4 more times likely than a false negative. All right, so let's do the same thing again. We take our pretest probability. We now multiply it by the negative likelihood ratio. We got to do some math, and we come up with a number. All right, remember our pretest probability was 70% going in, picking up a melon, and having it be ripe. But now we did the shake test. And this time the shake test was negative. The negative likelihood ratio of 0.28, again, draw your line, 70% pretest probability, likelihood ratio 0.28, post-test probability of about 35% or so. This is probably one of the most important things for you to learn about diagnostic testing. And it's a trap that every one of us fall into almost on a daily basis. And that is, just because you have a negative test Have you completely ruled out the disease? The answer to that is no, you have not. You may move back down the line this way, all right, but don't get caught in the trap that if you have a very high pretest probability, let's take Mr. Kincaid, all right, 50 years old, has a history of some hypertension, has exertional chest pain, comes in complaining of chest pain, he's been diaphoretic, he's been sweating, all right? His first EKG is negative. Do you feel confident that you can say with a great amount of certainty that his chest pain is not caused from a cardiac etiology? How many would feel comfortable that the EKG completely rules out the possibility of it being a cardiac etiology? Good. No one does. That's a great example of you have a very high pretest probability, you have a negative test. It doesn't make your post-test probability now so low that you should discard it and not think about it. And that's the trap we get into a lot of times. Negative test must not have the disease. Is the post-test probability less? Absolutely. Does it rule out the disease? Absolutely not. And again, if you use a 50% pretest probability, negative likelihood ratio, you see that your post-test probability is 20%. But you also see, as you get with a negative test further away from one, you can see how much more it impacts the post-test probability. So how good is the shake test? I'm not really sure. And we'll talk about that on another day. So I think hopefully now what you can see is that your likelihood ratios probably give you better information in order for you to move up and down your diagnostic probability line. It's much easier to know that if you have a likelihood ratio positive for a test that's 10, all right, that's probably going to move you way up this way. All right? So again, the further you get away with one for a positive test or going the other direction for a negative test, the more it helps you move up and down this line. Again, remember our jury analogy. What do we want from a diagnostic test? We want true positives. We want true negatives. We don't want false positives, and we don't want false negatives. But unfortunately, no test is perfect. So let's bring this home with a real-life scenario. All right? A 30-year-old female feels a lump on breast exam. All right? From prior studies, we already know what the sensitivity and specificity for a breast self-exam is. It's 54% for sensitivity and 94% for specificity. Taking that, then, we can now calculate a likelihood ratio, and that likelihood ratio comes out to be 9. In other words, a breast lump is 9 times more likely to be found in a woman with the disease as opposed to a woman without the disease. It's 9 times more likely to be a true positive compared to a false positive. All right. We also know from prevalence studies that the pretest probability of a 30-year-old woman to have breast cancer is 1 in 4,000. All right? So now we can do all that math that we talked about. Probability, change to odds, multiply by the likelihood ratio, get a post-test odds, change it back then to post-test probability. So if you do that now, the patient has a 1 in 444 chance of having breast cancer. But now let's take a different patient. Let's take a 50-year-old female, and she also has a family history of breast cancer. I think all of us would intuit immediately that her pretest probability is higher than our 30-year-old. All right? And actually, prevalence studies show that, again, a 50-year-old female with a history of breast cancer in the family has a 1 in 100 chance of developing breast cancer. And now she, during her self-exam, feels a lump. And we know what the likelihood ratio is. We do the math again, and now we see that the patient has a 1 in 11 chance of having breast cancer. So hopefully this example shows you that depending upon what your pretest probability is, all right, it's really going to drive then what your post-test probability is going to be. And you can see the difference between our 30-year-old female and our 50-year-old female with a family history of breast cancer. All right, 2 rules to remember, just 2 mnemonics that I just want you to tuck away right now, and you'll talk about these in your small group sessions as well. Snout and spin. Snout and spin. A highly sensitive test, when it is negative, it helps rule out disease. A highly sensitive test that is negative rules out disease. Snout. The classical example of this is you don't want to let people slip through. How many of you have been to the airport in the last 6 months? How many of you have had to go through a metal detector? All right. Now, do you want that metal detector to have false negatives, or do you want it to have false positives? Why don't you want it to have false negatives? Because something bad might slip through. A highly sensitive test, when it's negative, rules out the disease. The other mnemonic is spin. A highly specific disease, when it is positive, it rules in the disease. Write these down and just maybe to start thinking about them a little bit and see if they make sense to you. All right. 2 more slides and we're done here. So, what are our take-home points today? Our take-home points are there are pros and cons to testing. All right? We talked about how testing helps alter our pretest probability. It strengthens our estimates. It helps us move us along that diagnostic probability line. But there's cons to testing as well. We talked about time. We talked about cost. We talked about complications. And we also talked about the fact that tests are not infallible. With testing, you will get false positives, and with testing, you will get false negatives. And we spent a lot of time talking about decision-making thresholds and how we move along that line till we get to the point where we've done enough testing now, it's time to treat, and vice versa, we've moved further to the left of that line to the point where we don't need to do any more testing. We are sure we've excluded that diagnosis as a possibility. Remember odds and probability. Remember the difference between the two. Remember about throwing darts at our figure and helping to remember what probability is and what odds are. Also remember that mathematically you can go back and forth between the two. All right? We talked about study design for diagnostic testing. We talked about reference standards or gold standards. We talked about blinding. We talked about spectrum and things like that. Again, this will be talked more about in your small group sessions. And then we spent time talking about the 2x2 tables and how you come up with 4 different choices. True positives, true negatives, false positives, and false negatives. And then what we try to do today is to teach you some new language, some new nomenclature, some new stuff that helps you tell other people or helps you interpret studies about testing to see how valid that testing is. Remember, we want tests that are valid. We want tests that take us to the truth. And sensitivity, specificity, positive and negative predictive values, and likelihood ratios are ways of describing and telling other people and telling you how valid tests are. We've talked about then taking a pretest probability, taking the likelihood ratios, and then coming up with a post-test probability. And then just I briefly mentioned spin and snout. All right, do we have any questions? All right, go Boilers. Thank you very much.